Hello, welcome to my channel. This is Simplifying NCLEX, where we make everything about NCLEX simple for you. So if you're preparing for the NCLEX examination, this is a channel to be, because we talk about all the important topics you need to know before your NCLEX examination. Today we want to look at increased intracranial pressure. And what is intracranial pressure? Intracranial pressure is the amount of pressure that is in the cranium. It's as simple as that. So let's have a little illustration. Let's take this to be the skull, and within the skull we have some components of the skull, which is the brain. This is just for illustration. And let's take this to be the CSF, which is your cerebrospinal fluid, and then we are going to have blood. So these are the three components of the cranium, and your intracranial pressure is just saying the pressure within the cranium. And when the pressure within the cranium becomes increased above the normal, we say that there is increased intracranial pressure. You know that the cranium is rigid, it's not able to expand. So every component of the cranium has been given some proportion. And let's say we have the brain giving 80%, we have the CSF giving 10%, and we have the blood giving 10%. So for this individual to maintain the normal intracranial pressure, these components need to maintain their proportion. And nature has it that if any of the components actually increases, the other two need to decrease to accommodate and have an equilibrium. So in other words, if we have an increase in the flow of blood to the cranium and the blood exceeds 10%, you find out that the CSF and the brain need to decrease, need to adjust to make sure that pressure within the cranium is maintained. And nature does this by a lot of ways, like your vasoconstriction, reducing the blood flow to the cranium by channeling the cerebrospinal fluid to the spinal cord, or reabsorbing it back quickly, or actually not producing it so much because there is an increased intracranial pressure. What is the normal ICP? We want our patient to have an ICP of 5 to 15 millimeter mercury. Okay, this is an NCLEX point you need to know. And we become alarmed when this intracranial pressure gets above 20 millimeter mercury. And for your NCLEX point, at this point you need to report. Okay, so this is the point where you need to report to the HCP. When you have an ICP that is greater than 20 millimeter mercury, you need to report to the HCP, because it's showing that your patient is having an increased intracranial pressure. Let's go to the causes now. What is it that can cause the brain tissues mass to increase to get above this 80%? Let's think about things like tumors. Let's think about things like abscess. Let's think about things like inflammation. When we talk about inflammation, we talk about infections like your meningitis and your encephalitis, where you have the meninges of the brain being inflamed. Okay, now for CSF, if we have anything that leads to an increase in the production of CSF, that's going to lead to increase in intracranial pressure. And if we have where there's obstruction to the flow of CSF or its reabsorption, like we see in your hydrocephalus, we're going to have increased intracranial pressure. And for blood, if we have any form of bleeding, any form of hemorrhage, your hematoma, your cerebral erosion, all those ones are going to lead to more volume of blood in the cranium, and indirectly we're going to have the intracranial pressure increasing. And then, have you thought about traumas? Yes, when we have closed head injuries, that's injuries to the brain, is going to actually lead to the intracranial pressure increasing. Now we are going to look at some of the terms we need to know that will help us when we are studying intracranial pressure. It's important we look at these terms, because these terms will give us an overview of what we need to know in intracranial pressure. So the first term we want to look at is your CPP. Your CPP is the cerebral pulse, cerebral perfusion pressure. So Cerebral perfusion pressure is the amount of pressure available for the cranium. That's showing you what's the amount of blood flow to the cranium. That's your cerebral perfusion pressure. And medically, we calculate this by saying MAP, which is MAP minus ICP. So your MAP is your mean arterial pressure. And the mean arterial pressure, how do we get it? We are going to double our diastolic blood pressure, and then we are going to add it to our systolic blood pressure, and that is divided by 3. So double your diastolic blood pressure, add it to your systolic blood pressure, divide it by 3, and then we have our MAP. For NCLEX, you don't need that, but it's an information you need to know as a nurse, how you get your MAP. So your cerebral perfusion pressure, you get it when you say MAP minus your intracranial pressure. This is very important for you in this topic because your CPP is indirectly related to your ICP. Anything that makes your patient to have an increased intracranial pressure is going to indirectly lead to a decreased CPP. So that patient who has an increased intracranial pressure is going to have reduced blood flow to the cranium, and indirectly, reduced blood flow to the cranium is telling you that there's reduced flow of oxygen to the brain, and this patient is at a very high risk of what? Cerebral hypoxia. So this is one reason why intracranial pressure is very important, because of the cerebral hypoxia, which if nothing is done, know that this patient brain tissues can die off, ischemia can occur. All right, so this is one thing we need to know. It is important I tell you the normal range of CPP. We want the patient's CPP to be within 60 to 100 millimeter mercury. That is the normal cerebral perfusion pressure. Now, another thing we need to look at that will help us in this study is our pulse pressure. We want to look at what is pulse pressure. Your pulse pressure is the difference between your systolic blood pressure and your diastolic blood pressure. So in essence, if I have a blood pressure of 120 over 80 millimeter mercury, for me to get my pulse pressure, I'm going to say 120 minus 80, and that will give me 40 millimeter mercury. Fortunately, this is the required or normal pulse pressure we want our patient's blood pressure to be. We want that anytime we take away the diastolic blood pressure for the systolic blood pressure, we should be having 40 millimeter mercury. So keep that information. Another thing we need to talk about that is very important in this study is your Glasgow Coma scale. So your Glasgow Coma scale is going to be very important in this ICP, because this is a tool that the nurse is going to use to assess this patient, to know if this patient is declining. By declining, we mean this is a tool that shows you if the intracranial pressure of this patient is increasing. Okay, so it is like response we elicit from the patient. We want to elicit this response by asking this patient to know if this patient is oriented in place, in time, and in person. And when we do this, what do? We ask a lot of questions, and we actually try to look at the patient's response to what? To pain. The patient's response even while we are examining the eye movement. Okay, when the patient is rotating the neck, the head, we want to know how the eye is moving. Now, this GCS is very important. You know it as a nurse in ICP study, because there are some important numbers. Now, it is scored just like the way we do our scoring 1 to 10. The highest score the patient can get is 15, and that is good. We want our patient to have a GCS score of 15. That is good. It is showing that this patient is alert and oriented, and the intracranial pressure is okay. Now, we want to watch this patient because we are suspecting probably this patient has had a brain injury, and we want to know anytime the intracranial pressure increases. So we keep on checking this patient, and let's say, for example, you check the patient after another 1 hour, and then the patient is having 14, a score of 14, and maybe you come back again and the patient is having a score of 13. That is a declining GCS. Once I say declining GCS, you need to inform the HCP increase intracranial pressure. And that's something you don't want to keep quiet about, because you know what this intracranial pressure can do to your patient. It can lead to cerebral hypoxia, and actually your patient can have the brain tissues dead if nothing is done urgently. Okay, now still talking about the GCS, we have talked about a declining GCS, and we have said that we're reporting to the HCP. Also, there are some numbers we need to know. The number 8 acts like the in-between, okay? And anything 8 and below is showing you that this patient is unconscious. Very important. Sometimes you have NCLEX telling you, giving you a case scenario of a patient who has a GCS score of 6 or 7. They won't tell you that this patient is unconscious because they've given you a GCS score. So because they've given you that GCS score, it is expected that you should know that you're dealing with an unconscious patient. So any GCS score that is 8 and below is actually showing that that patient is what? Is unconscious. Very important that you know that, okay? Now, I will talk about the lower GCS score, which is an important landmark again that you need to know. Now, the lowest GCS score is 3. And if you have a GCS score of 3 for a patient, it's actually showing you that this patient is unresponsive and must be in the comatose state. When can you intubate your patient? You can intubate your patient once your patient is a GCS score of 8 and below. If you need to intubate the patient because the patient is struggling, you can do that. All right. Then I will talk about our ventriculostomy. Very important. This ventriculostomy is like a surgical procedure where a catheter is inserted in the lateral ventricle of the brain, and we do that because we just want to relieve the pressure in the brain. So what we do is to make a surgical bore into the cranium, and we put this catheter, and the aim of this catheter is to channel the CSF down to the spinal cord or any other place, okay, in the body. We can also use this ventriculostomy to monitor the ICP. It can record the ICP reading pressure. And this ventriculostomy can be what? It can be temporal and it can be permanent as a shunt. It is important just for you to know that this is a surgical procedure, and because it's an open surgery, it can actually predispose this patient to what? To infection. And if you have a patient who has undergone ventriculostomy, you need to watch out for increased temperature, because that might be a sign that the patient has an infection. Okay, so let's go to our signs and symptoms now. Having said that, for signs and symptoms, we want to group it into early and late. For the early, let's talk about the early. The early is that sign that you're going to see that will tell you that your patient is having an increase in intracranial pressure. And what should come to your mind in early is a declining Glasgow-Coma scale. Once you are seeing that this patient has a declining Glasgow-Coma scale, it is a first sign. It's going to be restless. It is that patient who can be irritable. It's that patient who can be confused. It is that patient who can be sleepy. It is that patient who can be drowsy. And it is that patient who will have like an altered level of consciousness, can have an altered mental status. Now, coming to think of it very well, let's say this patient has come to you and there is a head injury, and you are monitoring for ICP using your GCN, and you have asked this patient, where are you? And this patient was able to answer you. And then you come back after 1 hour and you're asking this patient, where are you? And the patient cannot even understand where he is. That patient is already being confused. You can see this person very restless. You can see that this person has an altered mental status, is not able to understand where he is, why he's there. You can see there are changes in the mental status of this individual. That is the first sign to show you that your intracranial pressure is what? Is increasing. Alright? So these are very important. You know them. They are the early signs. It is just remember that your GCS is going to be dropping, declining, and you are going to have an altered level of consciousness, which can result to being restless, irritable, confused, sleepy, drowsy, or having an altered mental status. Okay? Then other signs you need to know that are very important is vomiting. So this is an NCLEX point, because I like that question very well. This is that patient that can actually present with vomiting, but the special thing about this vomiting is that this vomiting is going to come without nausea. So we have vomiting without nausea. So you're going to see a question that's telling you or asking you about this patient who is vomiting without nausea. And another wonderful thing or peculiar thing about this vomiting is that it's going to be what? Projectile. So it's going to be a projectile vomiting and without nausea. Then let's talk about headache. You should appreciate headache because everything is happening in the cranium, and because it's happening in the cranium, this patient is going to be complaining of constant headache. We can now go to the late signs and symptoms. For the late signs and symptoms, I will make it very easy for you. Let's imagine, remember, the cranium has the brain, the spine, cerebrospinal fluid, and the blood. Now let's think about it. When the pressure within it is increasing, let's say it is blood, and blood keep on accumulating there, what is going to be happening? The components of the cranium will be shifted. They will be displaced from their position. And what do you think will suffer much? The brain. The brain is going to be compressed. The brain is going to be displaced from its position. And you remember the parts of the brain. At a time, you're going to have the brainstem involved in this injury. If the pressure continues, the brainstem is going to be involved, because the compression of this brainstem is going to lead to a lot of changes in the patient's body. The brainstem, remember, helps very well in your vital signs. So indirectly, your vital signs will go haywire when the brainstem is involved. So I'm going to place it there because it's going to help you a lot when we're talking about this late. So let's talk about what happens. There's going to be an increase in blood pressure. That's important for you to know. And then you're going to have irregular respiration, which we call the chain stroke. Now, the chain stroke is an irregular respiration where this patient has irregular respiration and then periods of apnea. So there's this period where this patient is not respiring at all. And we still have increased temperature. The hypothalamus will be a kind of involved, and then we have increased temperature. And when you go to other parts of the body, let's look at what happens. If you go to the eyes, that's the vision of this patient, you're going to see that the pupils will be what? Will be fixed and dilated. They'll be fixed and dilated. If the brainstem is involved, they'll be fixed and dilated up to 8 millimeter. Remember, we want to keep the pupil at 2 to 6 millimeter, but here you're going to see the pupils fixed and very dilated. But if the brainstem is not involved, the individual or the patient is going to have your door's eye, which is what you want. When the patient is rotating the head, you want the eyes to be moving in opposite direction. And when you now go to, let's say, okay, stay with the eye, you can have your papilloedema there. Very important that we know that. Now, if we go to the arms, I'm trying to bring out the key landmarks for you, like looking at the patient posture. How will this patient who has actually had an increase in intracranial pressure present? So for the arms, we have two important posture we need to know, and that is your decorticate and your decelerate. So for the decorticate, we call it the flexor posture, because here you have the patient's hand flexed and towards the midline. So the patient is going to be like this, okay? And if the patient is in this decorticate position, it shows that the brainstem is not involved. But for decelerate position, which we call the extensor position, you're going to see that this patient is going to have the hand flexed, but is going to be alongside the body, okay? While the decorticate position is going to be within to the midline, the decelerate is going to be just by the size of the patient. So the arms are by the side. Now, which one is showing us that the brainstem is involved? The decelerate. That is the worst one, and that's the one that's showing you that the brainstem is really involved in that injury to the cranium. Okay, so it shows that the intracranial pressure has increased so much, and the brainstem is now very much involved. Okay, now let's go to the foot. What is happening in the foot? Okay, let's talk about the foot. What is happening in the foot? In the food, there is a reflex that is very important, and that is the Babinski reflex. The Babinski reflex is a normal reflex that actually happens in infants. Okay, when you stroke the sole of pressure, and because this adult has an increase in intracranial pressure, you're going to see that if you stroke the sole of feet of this adult, it is going to what? The toes will fan out. So we call it a positive Babinski reflex, which is not what we are expecting. We don't want that. All right. The Babinski reflex, it is normal in an infant, but in an adult, it is no longer normal. And this patient who has an increased intracranial pressure is going to have a positive Babinski reflex. Okay. All right. Now, let's continue. If you are enjoying this lecture, you can support my channel by subscribing to my channel. You're just going to hit the subscribe button and hit the notification button too, so that anytime I upload a new video, you would be the first to know. All right. Okay, so we have other signs that we're going to talk about, and then we go to our nursing intervention and medication. Okay, having talked about the food, now let's look at what happens in the neck. What do you think will happen in the neck for a patient who has an increase in intracranial pressure? That neck is going to be stiff. Okay, so your stiff neck, which we often regard as the nuchal rigidity. Okay, so we have a stiff neck, which we say medically is the nuchal rigidity. Okay, and it actually means that this patient is not able to use the chain to bend down to the chest. Okay, that is important, the nuchal rigidity. Let's talk about an important symptom when it comes to increasing intracranial pressure, and we call that the Cushing reflex. It has no relationship with your Cushing syndrome, please. Either it's called the Cushing reflex or you call it the Cushing triad. What happened is still around the vital signs. Remember, you have your blood pressure increasing, and in compensation, the body is going to drop the heart rate. So the heart rate drops, which is your what? Bradycardia. And we have a drop again in your respiratory rate in compensation of the increasing blood pressure. Okay, and then you have an important one, which is widening pulse pressure. Remember, we talked about pulse pressure. We said it's the difference between the systolic and the diastolic blood pressure. Now it's going to be widened. So let's give an example. We have this patient coming in with 120/80. The pulse pressure is 40. Then you are going to see that the systolic keep on rising. So we have 130, maybe 70, and we can have 130, 60. So the gap between the two, when you take away 170 from 130, see that the pulse pressure is going to 60, it's going to 70, and we keep on widening like that. That's what we call the what? We call the Cushing triad, and it's peculiar to increase intracranial pressure. I would like to do a little comparison for you for the sake of your new generation NCLEX. Now let's compare ICP, increased ICP to shock, using these vital signs that we're talking about now. In increased intracranial pressure, you're going to be seeing what? What is going to happen to your blood pressure? Fine, it's going to be increasing. But in your pulse, what's happening to your blood pressure is going to be what? Decreasing. And I told you that the body is going to compensate, and we have the heart rate what? Dropping. Heart rate is dropping here. And in your shock, what is going to happen to your heart rate? Your heart rate is going to be what? To be increasing. Respiration, what happens in intracranial pressure increase? We're going to have the respiratory rates dropping. Whereas in shock, we're going to have the respiratory rate what? Increasing. The patient will be hyperventilating. Very important. Put that at the back of your mind. Then other signs that we can talk about is that this patient can be unconscious. This patient can be having seizures, hemiplegia, that is loss of your motor usage, and the patient can even be comatose. Okay, I would like to mention some peculiar signs and symptoms you see in infants and explain why they happen. Now, for infants, one important thing we want to talk about is the bulging frontanel, and I want to tell you why it happens. The bulging frontanel, you know, the suture line of the infant are not merged together, so the suture lines are still gaping, they're still open, okay, in that infancy period. And you find out that if there is anything that increases the intracranial pressure, it's just like, imagine the blood flow to the cranium and there is bleeding within the cranium, it bulges out. And that's how you see the bulging frontanel. It looks like the first sign you're going to notice when this child is having an increase in intracranial pressure. And another thing is they can have the papillary edema, which we talked about, within the eyes, that's swelling within the eye, and the sunset eye. How do we make diagnosis for ICP? It's important I tell you that your first important diagnosis is your CT scan. Please, never you choose MRI over CT scan. CT scan is the quickest and the fastest you can use to determine if there is an increase in intracranial pressure. Okay? And an important NCLEX point you need to know, no lumbar puncture. Our lumbar puncture is a no-no, or your lumbar tap. Okay? Your spinal tap. You don't want to do a lumbar puncture, don't want to do a spinal tap to that patient who has an increased intracranial pressure, because you want to avoid the complication. What is the important complication we want to avoid? Brain herniation. The brain herniation is what we are avoiding. And when you do a spinal tap for someone who has increased intracranial pressure, you're going to help the brain herniate quicker. That takes us to our nursing intervention. So for our nursing intervention, we want to talk about what we can do to this patient who is having intracranial pressure. This is a safety exam. They want you to know those things that can put your patient in danger. And increased intracranial pressure is one of them. So I'm going to talk about the nursing consideration or intervention on priority. What is the first thing you do? A patient falls down or a patient comes to you and you could see that your GCS score is going down. What do you do? The first and foremost thing you do is immobilization. Immobilization, that's what you want to do, because you already know that it's something that has to do with the cranium. So I want to keep the head and I want to keep the cervical spine neutral. And what do I mean by neutral position? Putting them within to the midline. I don't want to flex it. I don't want to extend it. Okay? So what do I want to do? I want to put it to the midline. I want to align it very well. So immobilization, which we can do with pillows or whatever, but our main aim is to immobilize the head and the cervical spine. Then immediately you finish your immobilization, you go to your positioning. What is the best position to keep a client who has an increase in intracranial pressure? I want to put my client in a semi-Fowler's position, which is a position that is not flat and a position that is not too high. Okay, so we are looking at putting this patient at 30 to 45 degrees. That's what we want to put the head of the bed. All right, we want to maintain that neutral semi-Fowler's position, not a high Fowler's position and not a flat position. This semi-Fowler's position is going to help drainage. All right, all we want to do is that we know that something is building up in the cranium and that's why the pressure is high, so we want to enable venous drainage. Now immediately I position my patient, I want to oxygenate. I'm going to tell you what happens, because there is a connection between an increased CO2. If a patient is hypercapnia or a patient is having hypoxia, okay, if there is hypoxia or increased CO2 hypercapnia, you're going to see that it's not going to help increase intracranial pressure. Let me tell you what happens then. Once the brain is not getting enough oxygen, that's your hypoxia, or the body has sensed that there is an increased level of CO2, that is a CO2 level that is more than what? More than 45. Now what happens? The body is going to go into what? Vasodilation. Now, vasodilation is just like opening up the blood vessel to push in more blood to the cranium. The body is doing that because, we can't get more oxygen to the brain. We need to do something. So they keep pushing in more blood. But what is happening in the recent? The body is not helping because the intracranial pressure of this patient is high. So when more blood is being pushed to the brain, you are increasing the pressure within the cranium, and that's not helping the patient. And because of it, that's why we don't want this patient to become hypercapnic, neither do we want this patient to become hypoxic. Okay, and that's why we do what? That is why we do the oxygenation. Now, school of thought have it that you are not going to have oxygen for a long time. Instead of us allowing the CO2 to keep on rising, we are going to have vasodilatation. But whenever we oxygenate the patient, it becomes the opposite. So we're going to have vasoconstriction. All right, that is important. Now, there are things we need to teach the patient to avoid. That is important. A lot of things. There is a connection between increased abdominal pressure and increased intracranial pressure. So increased intra-abdominal pressure is going to directly increase the cranial pressure. So anything that will increase intra-abdominal pressure, we don't want our patient to do it. For example, straining, that's your Vavasa maneuver. We don't want this patient to cough. We don't want this patient to sneeze. We don't want this patient to shiver. And that's why we manage pain very well. We don't want this patient to vomit. And suctioning is avoided in this patient, but if done, it is done when necessary and shouldn't be more than 10 seconds. Okay? We don't want this patient to hold their breath, and we don't want this patient to actually do a deep breathing exercise. No. This is the patient that we don't want anything that will cause an intra-abdominal pressure, because that will directly increase the intracranial pressure. Now, it's important I tell you that if the patient who is having an increased intracranial pressure needs to be suctioned, you need to pre-oxygenate the patient before and after, and it shouldn't be more than 10 seconds. Another thing we can do as nurses is to put our seizure precaution. Our seizure precaution is very important, and you know what is involved in the seizure precaution? We talk about raising part of the bed rails. Don't raise all, because that is going to be like a false imprisonment. All right, so you're going to raise some of the bed rails. You make sure they are padded. You're going to nurse this patient not in a bright light. You're going to nurse this patient in a dim light, and you're going to reduce noise when you're nursing this patient. So that's our seizure precaution. And then we're going to manage pain. We want to manage pain because that's not the patient we want this patient to be as relaxed as possible. Okay, that is it. Now we are going to go into the medication we are going to use for this patient. If you can appreciate what we've been saying, you will by now know one or two medications that will be involved in the management of our patient. Because when you look at intracranial pressure, if you have understood what I have been saying, some of the medications you already know them. Okay, so we'll start from the known to the unknown. That's what we're going to do. So let's start from some of the medications you feel this patient we use, and then we go to the ones maybe we don't know that will help us. So let's start with our antipyretic. Remember we said we don't want our patient to see shiver. That's the patient we want to manage pain very well for. So our antipyretic is a medication. Okay, so next let's talk about antipyretic. Remember, we are expecting an increase in temperature, so we want to manage that temperature. We don't want that patient to have pyresia, so we want to use antipyretic to bring it down. Seizure. That's a patient who we know can have seizure, so we want to prevent seizures, and we can have our phenobarbitons and even our phenytoin is a drug of choice, and we want to look at steroids. We can use steroids to manage this patient, but there's something we tell you about steroids. Steroids, mostly we use it when it has to do with brain tissue, maybe tumors, okay? So we do that because it really helps. The steroids help to make sure that the whatever that is happening within the brain doesn't get worse. We don't use steroids when it's a traumatic brain injury. So traumatic brain injuries, we don't use steroids. That's something you just need to know. Okay, for TBIs we don't use steroids. Now let's talk about an important medication in ICP, and that's your mannitol. even if you don't take anything home, take this one home. Mannitol is very important because it is a drug of choice when it comes to the management of what? Of increased intracranial pressure. Let's talk about this medication a little. This medication is an osmotic diuretic. So you expect this patient to have diuresis, okay? And I will tell you some few things about this medication because it's important. It's a drug of choice for increased intracranial pressure. It's going to work having diuresis. It's going to absorb most of the fluid in the brain and take them to other parts of the body. The concentration is to decrease that intracranial pressure, and while it's doing that, it's going to take away the fluid that is building and then take it down to other parts of the body. So you're going to be seeing side effects very shortly after administering this medication. From 30 to 60 minutes that your patient have taken this medication, you're going to see the after effect, the side effect, which is what? Edema. Okay? You're going to see that. So that's the patient you want to look at the input and output, and that's the patient you want to look at something. Let's think about it. It's taking away fluid from the brain. It's really working hard to make sure that intracranial pressure is reduced, and it's taking this fluid other places. And I've told you that one major side effect it has is edema. So the heart is a problem when it comes to mannitol. That's the patient you need to watch out for heart failure, because it can take this fluid to the heart, and we're going to have pulmonary edema, and we are going to see this patient having heart failure. So very important, listen very well. Mannitol is a drug of choice when it comes to the management of ICP. We don't take it orally, it's an IV. We said that you're going to be seeing the side effect, which is edema, very shortly after administering it. Within 30 to 60 minutes, you're going to see it. And we're going to watch out to look at the patient's heart, because this edema is generalized everywhere in the body. So we want to watch out for the two important signs of heart failure, which is what? Crackles. And we want to watch out for pulmonary edema. Okay? If you see any of these two in a patient who is being treated for increased intracranial pressure with mannitol, you need to flag it. How do we know that mannitol is working well? We know that mannitol is working well when we actually see that the GCS is what? Increasing or decreasing? Increasing. That's it. The GCS is increasing, and if we are monitoring the ICP using the ventriculostomy, we can see that the ICP is what? Is decreasing. Okay? And we have a medical surgery we can do to help intracranial pressure, and that is your craniotomy, where we actually take part of the cranium out just to give space for expansion to accommodate whatever that is increasing the pressure. If you have enjoyed this lesson, I really want you to follow my channel, because I have many more videos to do where I'll be showing you other important topics you need to know before your NCLEX. Thank you so much.